Everyone. I'm Kira Curtin, Managing Editor at GenomeWeb's Precision Medicine Quarterly, and I'll be your moderator today. The title of today's webinar is Multiparameter Approach to CLL Diagnosis, Prognostic Biomarker Assessment, and MRD Monitoring, and is sponsored by Invivoscribe. Our speaker today is Joseph Annunziata, the Director of Laboratory Services at Kindred Healthcare.
Hi, good afternoon. So the title of this talk is going to be Multiparameter Approach to CLL Diagnosis and Molecular Update on Predictive and Prognostic Biomarker Assessment. I have a wealth of experience both as a diagnostic hematopathologist and a molecular pathologist, in addition to signing out a general CP and laboratory administrative duties, and see several CLL cases daily. I have a few disclosures to make, being on the speaker bureau for Tempus, Caris, and Amplity, and honorarium for this presentation by Invivoscribe. We will begin by comparing the various diagnostic approaches for CLL. I will present one patient case in order to illustrate the multi-parameter approach in diagnosing leukemia lymphoma. Next, I will highlight predictive and prognostic benefits of molecular testing in CLL, including touching on some simple but important risk stratifications in CLL. MRD methods will be assessed for long-term monitoring in CLL patients. Lastly, some exploration of flow cytometry-based CLL MRD and how it is relevant in regard to drug research and development will be discussed. So what is chronic lymphocytic leukemia? It is characterized by an accumulation of mature B lymphocytes. Patients are typically asymptomatic during initial assessment. So typically, when it is discovered, usually the clinician will order like a path review or a manual differential, and a flag will be assessed based on either atypical lymphocytes greater than 5,000 or just an inverted ratio, meaning more lymphocytes than neutrophils. And that's typically how we discover that the patient has CLL. It has a highly variable course of disease, and most of them are indolent, but it's only until recently that we have kind of unleashed our armamentarium of different predictive and prognostic ancillary tests. So it's the most common type of leukemia in Western countries. It has a 5-year relative survival of 87.9%, and it's more common in adults and among men than women. It's most frequently diagnosed among people aged between 65 and 74, and there were an estimated death number of 4,410 in the United States last year. So CLL, or chronic lymphocytic leukemia, is for the majority of patients an indolent hematologic neoplasm that is honestly not that difficult to diagnose, especially by utilizing a multi-parameter approach, but that due to its chronic nature, it presents challenges in clinical decision-making over the time course of the disease. And in my clinical practice, that's when the majority of some of these queries will occur. Later on in the patient's course of disease, questions from oncologists regarding predicting the clinical behavior of this CLL, whether or not it's transformed, and defining acceleration in terms of both morphologic and genetic means. Let's begin with a patient case. This patient is a 64-year-old female presenting to her PCP for annual history and physical. She has a history of rheumatoid arthritis and DCIS of the breast. She is a non-smoker and a social drinker. The patient complains of fatigue and joint stiffness with pain. The physical exam is unremarkable other than findings compatible with arthritis. The CBC shows a white blood cell count of 23.5, a hemoglobin of 10.3, hematocrit of 34, and a platelet count of 248. Peripheral smear is ordered with a pathologist review, as the manual differential shows more lymphocytes than neutrophils. And the pathologist decides to reflex to flow cytometry and FISH. So when looking at the peripheral smear, I would describe this as an absolute abnormal lymphocytosis composed of small-sized atypical lymphoid cells with round nuclei, clump chromatin, indistinct nucleoli, and scant cytoplasm. A few scattered pro-lymphocytes are identified. Mild normocytic anemia is noted. Platelets are normal in number and exhibit adequate size and morphology without platelet clumping. Typically, when I use the term an absolute lymphocytosis, usually it's a lymphocyte count of greater than 5,000. Then we order the flow cytometry next because these peripheral smear findings show abnormal or atypical appearing lymphoid cells that are not reactive in nature. This flow cytometry panel is used to compare and contrast the findings that were seen in this patient, but I've also included it to show a differential consideration. So let's say for the purpose of this discussion, the patient's cells are highlighted in red and green, whereas the cells highlighted in black are a reference. So the flow cytometry B cell tube shows 2 abnormal B cell populations, in addition to a T cell population. The green are the T cells, which are essentially normal. The population in black shows CD19 and CD20 bright positivity, CD5 and CD23 expression, CD38 absence, and surface lambda light chain monoclonal expression with bright positivity. These findings are worrisome but not diagnostic of a mantle cell lymphoma, but could still be an atypical phenotype for CLL. So one of the things that we would do is we could do additional flow cytometry markers, including CD200. We could do BCL1 FISH. And if the FISH is positive, it would be mantle cell lymphoma. If the FISH is negative, it could be a CLL, maybe an atypical phenotype. If you instead look at the population in red, it shows CD19 and CD20 dim positivity with CD5 and CD23 expression, dim CD38 expression, and no overt light chain restriction. This population could be compatible with CLL. Typically, we use CD200 as it is more sensitive and more specific marker than CD23. CD23 kind of being the CD200 of the past decade or so. But these are the findings that essentially you see in the differential of CLL versus a mantle cell lymphoma, which is typically the latter being much more aggressive, is that with CLL, you see much more down-regulated expression of the B cell markers. So CD19 and especially CD20 is very dim. It can even be almost negative. And when you do additional flow cytometry markers like CD79A, CD79B, FMC7, you see this downregulation of the B cell markers, whereas in mantle cell or marginal zone lymphoma, you see upregulation, so it's stronger. So this is a helpful pictorial representation of the differential diagnosis of a B cell population being evaluated by flow cytometry. CLL is a CD5 positive B cell leukemia lymphoma that shows typically, again, dimmer expression of the B cell markers, but they are typically expressed. Whereas mantle cell lymphoma is another CD5 positive lymphoma showing brighter expression of B cell markers. And that also goes for the light chains. So if it's kappa restricted or lambda restricted, the actual intensity by flow cytometry of these light chains are stronger in mantle cell or marginal zone lymphoma, but it's very weak in CLL to the point where sometimes it's difficult to ascertain which light chain it is actually expressing. CD23 is often expressed in CLL. It's not typically expressed in mantle cell lymphoma, though it's not specific. It can be expressed in lymphoplasmacytic lymphoma and rare mantle cell lymphoma cases. CD200 is a much more specific marker, and some have replaced it in their panel, or yet others, like us, we just use it in conjunction with CD23. Marginal zone or lymphoplasmacytic lymphoma is a CD5 negative, CD10 negative B cell lymphoma that often but not always lacks CD23 and shows bright B cell marker expression. And follicular lymphoma is very classically CD10 positive, typically bright with dim CD19 expression. And also the level of CD38 expression is usually higher than that of other B cell malignancies. It is important to differentiate CLL from monoclonal B cell lymphocytosis, or MBL. CLL requires that the peripheral blood monoclonal B cell count exceeds 5 times 10 to the 9th total WBC. If there are biopsy-proven infiltrates, proliferation centers, lymphadenopathy, or splenomegaly, but the total WBC count attributable to CLL, which would be quantitated by flow cytometry, is less than 5 times 10 to the 9th per liter, the diagnosis would be small lymphocytic lymphoma, or SLL. But if there's no lymphadenopathy or splenomegaly or other organomegaly, that's when the term MBL should be used. So going further within this MBL concept, it is broken down between low count and high count, because patients with low count show an extremely low risk of progression, whereas high count MBL progressively increases with risk to CLL transformation of about 1 to 2% cumulatively each year. The patient can be counseled, as this is a terminology that has been used for probably the past decade at most, but no modifications to clinical management would occur in patients with low count MBL. However, if the patient has a high count MBL, what we've seen is more frequent outpatient visits with their oncologist, more close monitoring with CBCs, and occasionally a flow cytometry test to repeat the quantitation for tracking purposes. This is actually an extremely common phenomenon, this MBL. It is typically incidentally detected by doing flow cytometry for another reason. We get flow cytometry orders for anemia or thrombocytopenia or any other reason. And I would say that the incidence rate, from what I've read for MDL, is about 4 or 5% in patients who are around the age of 65. Now, characterization using NGS, there was a Memorial Sloan Kettering study, and more than 1,000 samples were tested over about a year and a half. And in comparison to capillary electrophoresis, NGS showed a superior performance while also maintaining concordance. And when assessing 281 CLL SLL cases, the IGH FR1 primers detected clonal rearrangements in more than 96% of the cases. Addition of the leader primers yielded close to 100% clonal detection. Now, moving forward, let's discuss the multi-parameter approach regarding the prognosis of CLL. This area has evolved from the incorporation of FISH and sequencing, where for quite some time we were mostly using flow cytometry-based prognostic markers. Described in this table are common prognostic factors in CLL, stratified into three categories as indolent, intermediate, and aggressive. From the laboratory perspective, IGVH is a strongly recommended test that we perform as a send-out test in our laboratory for patients at diagnosis. FISH testing in our laboratory, we also perform at diagnosis, and we utilize a panel-based CLL prognostic assay that has 5 probes that include 13Q, 11Q, which is ATM, 17P, which is TP53, trisomy 12, and 6Q. The latter, which we added because it at times can be helpful if you have a lymphoplasmacytic lymphoma in the differential. We can also do a BCL1 FISH, either by break apart or dual fusion FISH testing. And based on the history and the flow cytometry immunophenotype, we may add that on to absolutely exclude mantle cell lymphoma. During the flow cytometry assessment, we provide additional prognostic information by including CD38 analysis, in which you must give a quantitative, positive, negative. You give a qualitative result, it's positive or negative, but it's based on a quantitative cutoff using 30% as the minimum number of CD38 positive cells required to consider it as positive. In my experience, ZAP70 is something that was previously used but has since been replaced. The evolution has instead, after CD38, we have also begun to incorporate a newer marker called CD49D in addition to CD38 for flow cytometric prognostic assessment. And it has it gives a similar prognostic information. However, it is said that there are some cases where CD49D positivity conferring an adverse prognosis where the CD38 might be negative. So in other words, it seems to be more sensitive and a better performing marker. We've been using it for a few months now. So moving on, this panel shows the various cytogenetic abnormalities that can be detected by FISH applied in the prognostic evaluation of CLL. Image A at the upper left shows 2 green signals of a centromere probe of chromosome 17 and 1 red signal of TP53, compatible with a p53 deletion. Image B shows 3 red signals within chromosome 12, consistent with trisomy 12. Image C, the bottom left, shows 2 green signals of centromere probe of chromosome 11, along with 1 red signal of the ATM gene. That would be an ATM deletion. And image D, by far the most common cytogenetic aberration in CLL, 1 signal of 13Q, so that's a 13Q deletion. So the reason that we do this is the CLL FISH prognostic panel providing different levels, 4 levels of prognostication, essentially, which can be combined with NGS if indicated to further risk stratify by using NGS to try to detect BRC3 Notch 1 and SF3B1 mutations. Looking at the table, if you have a TB53 abnormality, in which the fish can understand here, the fish can only detect the deletions. It can't detect mutations. So you'd have to do a PCR-based analysis or NGS in order to detect all of the possible P53 aberrations. Or if you have tissue, you can do P53 immunohistochemistry, and it's kind of agnostic to the aberration if it's a mutation or deletion. The P53 IHC will essentially stain many, like a high percentage of the cells. So the ATM deletion is in the intermediate level of risk category. Low risk is trisomy 12 or normal cytogenetics, and very low would be the common 13q deletion. And this has very pretty significant division in the 10-year survival percentage scores based on these cytogenetic or fish findings. So the flow cytometry image here is just depicting the CD49D expression in CLL cells that are shown gated in red, exhibiting bright CD19 expression and positive CD49D expression. In addition, dual positivity for CD5 and CD23 are seen. If you look in the middle row, it shows a different case with CD19 expression in the cells of interest, with 35% of these cells in blue showing moderate CD49D expression. I'd still call that positive. The same case showing dual positivity for CD5 and 23. But now if we move on to the bottom row, you see that it's absolutely negative for CD49D. And these cells co-express CD5 and CD23. So all of these are CLL cases. But in the first two cases, the top row and the middle row, they would both be considered positive, which confers an adverse prognosis. And it has a strong correlation with the already established prognostic markers, mainly CD38. But the bottom one is a textbook negative case. Somatic hypermutations are point mutations affecting the IGHV gene. The results provide important prognostic information for patients with CLL, SLL, or hairy cell leukemia, and testing is strongly recommended as standard of care in all newly diagnosed CLL cases. In our lab, we send out for this testing and diagnosis. Somatic hypermutation is defined as greater than 2% germline sequence difference, and unmutated or less than 2% status confers an adverse prognosis. Certain stereotype subsets further refine the determination of prognostic risk. Molecular testing should also be considered within the multiparameter context of all available ancillary data, including flow cytometry, FISH, NGS, clinical, and radiologic information. So sophisticated bioinformatics software automates the SHM analysis, outputting the type, mutation rate, and information about productivity. And the NGS findings, they correlate well with flow cytometry. CLL being the most common leukemia in the Western world, it's very important to risk stratify this chronic disorder for making treatment decisions at various time points in the patient's treatment journey. The distinction of CLL patients in these two categories exhibit markedly different behavior and outcome based on the presence or absence of somatic hypermutation in the IGHV genes of the clonotypic BCR. IGHV gene mutational status also has a strong predictive value for response to treatment, and there is a clear distinction in the median survival of patients with and without somatic hypermutation. This study shows that evaluating the SHM status is also a predictive test. It displays evidence for the importance of immunogenetic analysis in CLL, demonstrating that the SHM status for the IGHV genes were associated with a particular clinical response to chemoimmunotherapy regimens, such as FCR. FCR treated CLL patients with mutated IGHV genes were associated with superior overall survival and achieved long-term PFS, which was defined as the time from initiation of therapy until the development of progressive disease, initiation of salvage therapy, or death. Technical guidelines dictate whether the identified productive IG gene rearrangement leads to membership of a major stereotype subset. Considering the ever-increasing evidence about the clinical implications of BCR IG stereotypy, at least for certain major stereotype subsets, the IG network advises everyone to analyze the clonal IGHV, IGHD, IGHJ gene rearrangement for possible memberships in major subsets which are considered as portending an aggressive clinical behavior. An important milestone in the timeline of CLL-focused immunogenetic research was the observation that 1/3 of CLL patients carry quasi-identical or stereotyped BCR IGs, and they can be classified into subsets defined by distinctive sequence motifs within the IG variable heavy complementarity determining region. Mounting evidence suggests that patients assigned to the same subset have similar biological features and clinical course, often differing significantly from other patients within the same somatic hypermutation category. On these grounds, it has been proposed that patient classification based on the stereotypy can supersede the more generic categorization into unmutated CLL versus mutated CLL, at least for the major subsets. More recently, Eric participated in the development of a bioinformatics tool, which is available online and enables one to robustly and easily determine whether or not these particular gene rearrangements belong to one of the major stereotype subsets. Pay particular attention to the identification of subset number 2, as most cases belonging to this subset would otherwise be reported as mutated. And given the presence of a moderate level of somatic hypermutation, usually leading it to identify germline level below the cutoff. It is now well established that patients with IGHV3-21 have an inferior outcome, which is similar to unmutated patients and or patients with a P53 aberration. Other examples are the one in number 1, which I believe I had last week, which also is an aggressive course with a poor prognosis, and number 8, which is associated with a higher risk for Richter's transformation. The author used an NGS assay to improve and further stratify CLL diagnosis. These 2 cohorts were analyzed from previous studies. One looked at RNA from CD19 positive extracted cells and used the DNA from the libraries. The second cohort looked at peripheral blood and used DNA for the libraries. This led the authors to propose 5 new subsets that clearly show a better stratification of patient outcomes. These results demonstrate the power of NGS when it comes to identifying patient outcomes and the ability to select certain treatments. In summary, the IGHV, somatic hypermutation status, is one of the most robust prognostic markers in CLL. Somatic hypermutation testing is recommended as standard of care for all newly diagnosed CLL cases. ERIC guidelines recommend the use of leader primers and to use FR1 in difficult cases. So consider selection of a suitable assay, taking these guidelines into account. And subsets can be defined by distinct sequence motifs within the IGHV CDR3 region. Now I'd like to move on to MRD long-term monitoring in CLL. We have discussed in quite some detail already the diagnosis and prognostication of CLL, most of which also occurs at diagnosis, but the long-term monitoring thereafter has been a hotbed of research, and it's where clinical offerings are expected to expand in the particular future. Measurable residual disease describes a small number of cancer cells remaining in the body during or after treatment. Testing is used mostly for blood cancers such as lymphoma or leukemia. And there are different cutoffs and different sensitivities depending on if you're using flow cytometry, some form of PCR, like droplet digital PCR being one of the most sensitive methods, or NGS. And even within those three methodologies, every assay is not completed equal. So one lab's flow cytometry test versus another lab's flow cytometry test may have different sensitivity. And if that weren't complicated enough, even within the same lab, we can alter the sensitivity to the maximum limit if we're aware. For example, I had a case today of hairy cell leukemia, and we acquired 250,000 events, raising the sensitivity to 0.1% or 0.01%, sorry. And we detected the hairy cell leukemia at a level of 0.1%. So, but essentially what most labs do is if you're looking for a certain cutoff, let's say 0.01%, you'll acquire enough events in flow cytometry analysis, generally at least 200,000, in order to state that you can detect the presence or absence of measurable residual disease. And that's kind of different than minimal residual disease. Minimal residual disease typically involves acquiring even more events. We had a case last week where we did myeloma MRD, and we acquired 3 million events. In order to be confident in the event that you have a negative result, confident that down to that very, very minuscule sensitivity level, you did not detect any disease. So MRD long-term monitoring in hematopathology, whether acute or chronic, leukemia, myeloma, it's commonly achieved, most commonly using flow cytometry. Specialized tubes are designed for each purpose. For example, in various laboratories for which I've been employed, we've had separate MRD tubes, one for myeloma, one for BALL, one for AML, and we've also had enrichment processes for B cell and myeloma. In other words, we have beads for CD19 and beads for CD138, and they essentially act as an antibody sieve that can enrich only those cells in order to increase the sensitivity. This is something typically that we use downstream for other ancillary studies. So for flow cytometry, we will acquire more events in order to get a great sensitivity. And then after that, we'll use the antibody sieve process in order to enrich the B cells or the myeloma cells so that when we do FISH, we have a higher percentage sample because FISH involves manual counting. These enrichment methods could also include flow sorting we've used in the past. Flow sorting is something that's used very commonly in hairy cell leukemia, where you have a very small leukemia population in the flow sample. So you sort it out using flow sorting, and then you send that sorted sample to molecular, because you'll often want to get a BRAF mutation by PCR, for example. MRD assessment is certainly ready for clinical use. I suppose the pressing question would not be if it's ready, but which modality are you going to use? Flow cytometry, using this as the standard methodology and using a table taken from a journal article published in Hemisphere 3 years ago, it shows that a 6-color flow has a reported sensitivity similar to that seen with qPCR. One of the major advantages of flow cytometry is that it's widely available, including in most hospital labs. It's directly quantitative. The results are quickly available, usually within 24 hours. The biggest advantage is that the sample must be fresh, and degradation of the sample typically occurs over 2 to 3 days, and it can significantly affect its viability and thus sensitivity. PCR does not fall victim to that issue. It is highly sensitive, as well as using patient-specific disease-specific IGHV primers, but it is also not directly quantitative, and it requires a baseline sample. It is time and labor intensive, as well as expensive. One must take a cost, billing, and reimbursement into account with certain high volume tests in particular. The results may take several days. They largely require send out to a reference lab. High throughput sequencing is clearly more sensitive option. It can detect multiple mutations in a single test, but the disadvantages like PCR is that it's not directly quantitative. It requires baseline sample, and it's less widely available. However, with that being said, one must keep in mind that regarding prognostication, there's really not this great push for fast results. In my experience, the oncologists want the diagnosis very fast, and the overwhelming majority of this prognostic information, if there's superior test options, it can be sent out, time can be taken. It's not really a true disadvantage or a relevant disadvantage. Conventionally, somatic hypermutation testing has been performed using labor-intensive, primarily analog Sanger sequencing method, followed by PCR amplification of the clonal IGHV gene rearrangement in CLL cells. In comparison, the recent availability of NGS for this purpose allows for more versatile detection and direct identification of the gene rearrangements in neoplastic B-cell populations. The ability to identify specific clonal IGHV signatures in both baseline and post-treatment settings enables unique clinical applications of NGS, such as determinations of SHM status, MRD monitoring, clonal heterogeneity, and B-cell receptor Ig stereotypy. Looking at the images in panel A and B, you see the VJ sequence frequencies by NGS, in contrast to a standard PCR assay in C, D, and E, which is not as versatile as NGS analysis, which provides even more sequence-specific information that can, in some cases, lead to a difficult interpretation of the results. Flow cytometry for CLL MRD can inform drug research and development. It is an exciting part of the field with much more room for expansion. The common and standardized methods for MRD monitoring are represented by flow cytometry and real-time quantitative PCR. More recently, promising results have been obtained by droplet digital PCR and NGS-based approaches. more recently, chemo-free combinations of venetoclax plus rituximab, venetoclax plus obinutuzumab, or ibrutinib plus venetoclax have shown capable of inducing undetectable MRD in the bone marrow, opening the way to protocols exploring an MRD-based duration of treatment, aiming at disease eradication. Thus, beside a durable disease control, desirable particularly for older patients and or those with comorbidities, MRD negative complete remission is becoming a realistic prospect for CLL patients in an attempt to obtain long-lasting eradication and possibly cure of the disease. Here we discuss the standardized and innovative technical approaches for MRD detection in CLL, the clinical impact of MRD monitoring in chemoimmunotherapy and chemo-free trials, and the future clinical implications of this monitoring. These panels show PFS in A and C and overall survival in B and D at the end of treatment by MRD and additional response status. This was a study, a German CLL study group published in the Journal of Clinical Oncology in 2016. And it shows that MRD assessment improves prediction of outcome in patients with CLL who achieve partial response. Here is just one example of a clinical trial that I retrieved from clinicaltrials.gov, in which a combination of LOXO 305, pirtobrutinib with venetoclax was used in phase 2 to control previously treated CLL. The objective is to estimate therapeutic efficacy of pirtobrutinib consolidation in patients with detectable CLL in the peripheral blood following 12 cycles of venetoclax. The endpoint measured will be undetectable MRD in peripheral blood analyzed by NGS with a 0.01% threshold of sensitivity after 24 cycles of combination therapy. There are numerous secondary objectives requiring sensitive MRD evaluation by NGS in this study in both peripheral blood and bone marrow. And I anticipate the need for this sensitive type of testing to further inform and assist other trials that are ongoing or will come up in the future. CLL diagnoses requires a multi-parameter approach incorporating clinical, radiologic, CBC, morphologic, flow cytometric, FISH, and PCR NGS findings. FISH, flow cytometry, PCS, and NGS molecular testing in CLL offers numerous predictive and prognostic benefits. Flow cytometry, PCR, and NGS MRD methods are clinically impactful regarding long-term monitoring in CLL patients, and multicolor flow cytometry-based CLL MRD can influence drug development and help in the evaluation of therapeutic combinations. I'm going to turn it over to Kiara.
Thank you, Joseph. And so we'll now start the Q&A portion of the webinar. And the first question is, given that there are multiple 8-color panels in use, what are the benefits of a 10-color panel?
So one of the major, essentially the benefit of using a 10-color panel or just more colors in general is it's cost effective. That's really the main reason, because in a general routine flow cytometry panel, at least that is utilized in our lab, we're running 26 antibodies. And if you're running 10 colors versus 8, that means that in one tube, you can place 10 antibodies as opposed to 8. So it allows you to investigate the same number of antibodies using less tubes.
Okay. And for the comparison between Richter's patients with DLBCL-like lymphoma transformed from CLL versus CLL patients, what are the differences between these two disease types in terms of cell surface marker expression for flow, gene mutations for FISH, and compartment, like bone marrow, blood, lymph node, differences for MRD clones?
So in comparing CLL versus Richter's transformation patients, they don't really show that much difference in immunophenotypic marker expression by flow cytometry. They can be very similar. However, in other cases, they may have a shift where the B cell marker expression may brighten. It may become stronger because in CLL it's usually quite weak. They're more likely to have a P53 mutation. And they, of course, the gold standard is morphology. If you do a lymph node biopsy or bone marrow biopsy, rather than having small sized lymphoid cells with proliferation centers, you will lose the proliferation centers and just have sheets of large lymphoma cells. Differences in involvement. Diffuse large B cell lymphoma is very, very uncommon to involve the bone marrow, whereas CLL, it's much more common. So usually once it's transformed, you'll have organ involvement or lymph node involvement.
Is there a need for an integrated analysis pipeline for these various methods? Would that be helpful, or is analyzing them all separately sufficient?
So like CLL cases in general, I guess.
Yeah, or
Yeah,
more
so
general.
it can be problematic, and just conveying the information can pose a problem for our external clients that we serve, maybe 24 hospitals outside of ourselves. They actually have demanded a summary report because it's so complicated. You have a peripheral blood smear morphology review, a flow cytometry, a FISH panel, sometimes a cytogenetics, an NGS, and they've wanted like a summary report that puts everything in there. And while others don't do it, for myself, I always put in the summary report a top line, one sentence summary, like overall findings are compatible with X diagnosis with Y prognosis, Z predictive value. I believe very much in that because I know that the oncologists are very savvy, but I think a lot of it is it's just not easy. It's just very difficult for them to get all of the information and put all the information together. And I do believe it would be important because what if there's conflicting information? Like, what if there's a P53 and a 13q? Does that mean that the prognosis is still poor? Or does that mean it's intermediate because you have a very good 13q and a very bad P53?
Okay. Another question is can you let us know how ddPCR can be used for MRD? Does it rely on the initial clonal rearrangement information?
Yeah, so droplet digital PCR is a very highly sensitive methodology, and it does rely on the initial information.
Okay. Another question is, would you see a benefit in consolidating the main guideline recommended CLL molecular biomarkers in a single NGS workflow, for example?
Consolidating the guidelines?
The main guideline recommended CLL molecular biomarkers.
Yeah, I think it would be very useful. I think that there's a lot of guidelines out there, and I think the issue is that we have different sets of people following different guidelines. So you have oncologists that are driven by NCCN guidelines, and they're informed by ASCO conferences. Then you have pathologists who are driven by, at least for this, the WHO. And now you have the ICC guidelines. So now hematopathologists have two different guidelines, which are different. They're not similar. In many ways, they have some similarities, but in many ways they don't. And it's kind of fractured. So there either needs to be a unified guidelines for CLL, at least in this country, or you would have to kind of like adopt a unified guideline in each setting, meaning the WHO, the ICC, the NCCN, they could all adopt the same guidelines so that no matter where you go in the US, or elsewhere, you would have, it would kind of be harmonized.
Mm-hmm.
I think that's what needs to happen.
Okay. Let's see. Do you anticipate assessment of IgHV stereotypes as to become an element of the routine prognostic workup in CLL?
I do think that it will. I do think it'll become routine in the prognostic workup of CLL.
Mm-hmm.
It provides a lot of information. I would say, in my experience, it's unclear when in the patient's like CLL journey they would do this testing, because typically when it's detected, it's often incidental, and that may not be when you're considering treatment. But certainly it provides a wealth of information, and if you are considering treatment, that patient's most likely going to get that testing. And we've definitely we send out for it, but we also perform a lot of other prognostic testing, flow cytometry and FISH. And the FISH in particular, we've had to repeat several times per patient, because the feedback I've gotten from clinicians is, we need something to tell us. We really think it's aggressive. We really think they have lymphadenopathy now. We're struggling for you to give us markers of aggressiveness. So that's what's great about this, because all I can give with the FISH is a P53. That's the only one that would indicate aggressiveness. Okay. So last week I had one and it wasn't P53, and I was like, come on. And they were like, it's really behaving aggressive, and I sent it out for IgHV. It was unmutated.
Okay. Let's see. Do you think NGS or ddPCR might replace flow, or will flow always be needed as a complementary test?
That's easy. Flow cannot be replaced. So flow cytometry can't be replaced because it has both diagnostic and prognostic value. All of the tests that I talk about, flow cytometry is the only one that can achieve the diagnosis. If you're looking at the blood smear, if you're an experienced hematopathologist, sure, you can probably tell that something's CLL. But flow cytometry, according to Matutes, can definitively achieve the diagnosis of CLL. And honestly, you really don't even need BCL1 FISH to exclude mantle cell lymphoma if it has a typical phenotype. And if it has an atypical phenotype, then you do. So flow cytometry and FISH are kind of ingrained. And FISH, especially because reimbursement is so wonderful. Whereas for flow cytometry, it's been decreasing over the last 2 decades, or 3 decades.
Have you seen SHM status change during disease progression? Is that something you've come across?
Not that I recall, but I have very few patients in which we've done it multiple times.
Okay. Let's see. What do you think are the most significant barriers for labs that want to adopt standardized NGS-based testing for assessment of SHM stereotyping and MRD monitoring?
I think that it is the barriers are the common barriers for NGS adoption, which would be the cost and the ability to get molecular technologists with expertise in this work staffing environment.
Okay. And what frequency do you test patients for MRD? Is it 6 months? Is it yearly, or is it patient specific? And how are those decisions made?
So it's typically patient specific, and it's determined by the patient's oncologist.
Okay, well, that looks like all the time we have for today. We'd like to thank our speaker, Joseph Annunziata, and our sponsor, Invivoscribe. If we didn't have time to get to your question, we'll try to follow up with our experts. And if you'd like to contact Invivoscribe directly, their information is available here. And as a reminder, please look out for the survey after you log out to provide us with your feedback. If you missed any part of this webinar or would like to listen to it again, an archived version will be emailed to all attendees. Thank you for joining us for this Genome webinar.